Welcome everyone to this webinar on fertility and late reproductive age. This webinar is performed in collaboration with the European Menopause and Andropause Society, EMAS, and the European Society of Young Endocrinologists and Scientists, EYES. My name is Angelica Hirschberg, and I am gynecologist and professor at Karolinska Institute and Karolinska University Hospital in Stockholm, Sweden. And I'm also the current president of EMAS. And I will chair this session together with my co-chair, which is Kristina Saravinovska. And I would like you to present yourself. So please, Kristina.
Dear participants, good afternoon, and thank you for joining us today. I'm Kristina Saravinovska, and today I'm honored to be here as a representative of the Young Endocrinologists and Scientists Committee within the European Society of Endocrinology. And on behalf of the Early Career Group of the European Society of Endocrinology, I want to wish you a warm welcome to the very first part of our webinar series dedicated to female reproductive health, today focusing on fertility in late reproductive age. And thanks to the visionary efforts of the European Menopause and Andropause Society and the European Society of Endocrinology, this series of webinars has come to fruition. And together we've crafted an insightful, a unique program tailored to the interests of early career investigators. And I would very much like to thank our distinguished speakers for accepting the invitation to be part of this exceptional initiative. And I want to say that I'm beyond honored to be chairing this webinar alongside Professor Angelica Hirschberg, who is one of the pioneers and a distinguished expert in the field. And also a special thanks to Elena Armeni for her contributions and dedication, which paved the way for this exceptional collaboration. So without further ado, I'm honored to pass the webinar stage to my esteemed co-chair, Professor Hirschberg, who will introduce our first speaker.
Thank you so much. Maybe we could say something about questions and answers, how we will use them.
So we will have an open discussion after all the three talks are finished. So please feel free to use the Q&A section, write down all the questions, and after all the talks are finished, we'll be reading and our distinguished speakers will be answering. Thank you.
Very good. So then I have the great pleasure to introduce the first speaker, which is Dr. Evangelos Makrakis, who is obstetrician and gynecologist and specialized in assisted reproduction medicine. And you are associate professor at University of Nicosia, but also visiting professor at University of Athens in Greece. And you will talk about the first testing of fertility. So please, Dr. Makrakis.
Yes, good afternoon from Athens. Of course, I would like to thank you and the whole organizing committee for giving me this opportunity to participate in this very, very interesting webinar. And starting, I will share my screen. Is it okay, I think? Can you see my screen?
Yes, it's perfect.
Yes. So the first part of this webinar is about the investigation, the first line investigation that we should give to a couple of advanced reproductive age before referring to a specialist. That means that we will not go through the detailed investigations that we may carry out or ask for after the couple comes to an IVF unit, but the general first line simple, I would say, investigations that it might be useful to know as soon as possible before the couple comes to an IVF unit. Here in brief, the agenda of what we're gonna talk about. To start with some general aspects. First of all, infertility according to the WHO is a disease of the male and female or female reproductive system. And the definition is that is the failure to achieve a pregnancy after 12 months of regular and unprotected intercourse. And this is the most wide accepted definition according to WHO, ASRM, ESRE, and it is based in the fact that by the end of the first year, approximately 85% of couples will have achieved a pregnancy. Some health systems like in the UK and according to some other institutes like NICE, the definition goes to 24 months, 2 years of regular intercourse, but we will follow the 12 months definition as it is widely, as I told, accepted. But according to ASRM and ESRE, we need to start earlier the investigation, earlier than the 12 months, after 6 months of efforts in women, in couples where the women is above 35 years old, and even before starting the efforts in women above 40 years old. And this is not in order to start straightforward IVF or assisted reproduction, but in order not to lose valuable time in the case that there is an underlying reason that like a severe male factor, let's say, it is better to know it earlier in order not to lose time. Infertility is not a rare disease. According to the 2022 global statistics, approximately 1 in 6 people have experienced infertility in their life. And so you see that the estimated lifetime prevalence of infertility is about 17.5%. Also, you can see here the global map of the prevalence of infertility, and you can see that the European region is in the middle, let's say, of the prevalence, in order of the prevalence in lifetime infertility and period infertility. Lifetime is the chance of having infertility in the whole life, and period infertility is the prevalence during a specific period of time, usually the 12 months that I before. And this is another interesting thing, that you can see that there are no any more major differences as it used to be between high-income countries and low or middle-income countries. So it's a global effect, and 48 million couples and 186 million individuals worldwide live with the problem of infertility. And what about infertility in late reproductive age? What is advanced maternal age? Officially, advanced maternal age is the age above 35, very advanced the age about 40, and extremely advanced the age about 45. But in order to be realistic, in our times, advanced maternal age, it's supposed to be above the 40 years of age, very advanced about 45 years, and extremely advanced about 40 in daily practice. In the age, this is based on a number of women that come to seek help about their fertility. And according to 2019 Europe statistics, you can see that the mean maternal age at first childbirth in Europe is 29.4 years. And see how goes, the lines goes up, there is a remarkable increase. For my country, this is even higher, is 30.6 years, the mean maternal age at first childbirth. And there are in Europe 3 countries with mean maternal age above 31. This is Italy, Spain, and Luxembourg. And also the same happens to the other side, to the United States. These are statistics from 2014, and you can see that the mean age has been increased for all birth orders, and of course for first birth, and it is around 26.3 years. And what about the childbirth above the age of 40, the late reproductive age? You can see that the proportion of live births to mothers aged over 40 has been more than doubled between 2001 and 2021. And in 2021, it was 5.7%. 5.7% of the births were reported by mothers above the age of 40. And here you can see again how the lines rise from 2001. It's the 5.7%. Remarkable, again, continuous increase. The same happens in the United States. These are the statistics. Approximately 18% of births were reported by mothers above 35 years old. And the consequence is this, that you can see that the IVF cycles, and this is the European statistics of the year 2019, you can see that in all countries in Europe, approximately 19% of the aspirations of the IVF cycles, let's say, were performed in women above 40. And my country, Greece, is the first in the row where the 54.2% of IVF cycles were performed in women over 40. So it's a very, very, very common phenomenon with women of advanced maternal age. And what causes this shift? There are social reasons. Of course, the higher educational levels, more women work, and especially in male-dominated fields, we are not so supportive. We have cultural, lifestyle, ethical value shifts that led towards more people not feeling ready to have yet. Also, we do not have so supportive policies for childcare and parenthood. And of course, there is also the economic uncertainty, the unemployment, all this instability that makes the couple feel unsafe to continue for a family, to have children. And also there are, of course, scientific reasons for this shift, and these are the advances and the wider use of contraception, as well as the advances in assisted reproduction, giving the false impression that childbirth can be delayed. And this is not always correct. So how the advanced age may affect fertility? Let's talk about women. Fertility in women decrease. The fertility decrease starts from the age of 24 and accelerates after the 37 years of age. And this is because of the follicular loss. Women are born, as you know, with their follicles, with their eggs, and they cannot produce new follicles. They cannot produce new oocytes. And as you can see, women at birth, they have approximately 2 million of follicles, of oocytes. Then there are only 25 at the age of 37, and then the follicular loss accelerates even quicker. And when the follicles are off, then the woman enters to menopause. A matter of number. It is also a matter of quality, because we have impaired function of the mitochondria, increased apoptosis, increased oxidative stress, all these aging process that actually occurs in every single cell of our body. But also there is an endocrine problem. We have reduced ovarian sensitivity to gonadotropins as the age grows. And this is because the androgen levels keep reducing after as the age of the woman rises. And at the end, we have a increase of embryos with chromosomal abnormalities. And this is because the oocytes, after birth and until their recruitment and the ovulation, enter and arrest in the prophase of meiosis is through different mechanisms results in chromosome segregation errors. And this, of course, at the end results in embryos with chromosomal abnormalities that fail to implant, or they give abortions, or even worse, genetic syndromes like the Down syndrome. And you can see here in this table that the rate of aneuploid embryos keeps increasing along with maternal age from an initial 30% up to 90% in the decades. This is the red boxes in the decade of 40s. So we have many problems. Is the number, is the quality, is the endocrine profile, and is the chromosomally abnormal embryos. And what about paternal age? Because recently we have found and we have started giving, interest in male, in paternal advanced age. There are cellular and physiologic endocrine changes. We have decreased spermatogenic activity, and we have also age-related changes in the endocrine system, in the axis, with the average FSH levels to increase and the testosterone levels to decrease with advancing age. And the result is impaired semen parameters. We have decreased pregnancy rates and increased time to conception as the male age increases. And also we have other things like some quite rare, but they are still there, de novo autosomal mutation leading to specific disorders like achondroplasia. And also there is an association with offspring like bipolar disorders, even leukemia. So there is an advanced paternal age, and this is supposed to be the 40 to 45 years. And now let's move to the investigation that we should offer to men and women of advanced age that they are seeking a pregnancy. First of all, always, we must start from the medical history, because we can learn things and we can find many little things and from the history that may require a more specific investigation. We need to know regarding the female, the duration of infertility, the frequency of intercourses, any sexual dysfunction, the menstrual characteristics, if there is dysmenorrhea, dysporenia, the obstetric history, of course. Did we have pregnancies? Did we have deliveries? The history of gynecological operations or infections, and especially the sexually transmitted diseases, history of endocrine disorders, and of course lifestyle factors that may affect negatively fertility, like smoking, alcohol, illegal drugs. Also medication, allergies, and a brief family history, mainly for cases with premature menopause in the family. From the clinical examination, we have to check the BMI, the body mass index. We can see any suspicious vaginal discharge through the speculum examination. Through the PV examination, we can see if there is discomfort, tenderness. We must try to see if there are signs of hyperandrogenism like hirsutism and acne, breast examination, and examination of the thyroid gland. The first we need to know is if a woman ovulates. We have to document ovulation. Of course, the medical history, if we have regular cycles, this actually, in these cases, ovulation can be assumed. But in subfertile women, and especially in those of advanced reproductive age, ovulation ideally must be confirmed with a more objective method. Another quite common method is the basal body temperature measurement, because the corpus luteum after the ovulation secretes progesterone. This acts in the hypothalamus and causes an increase of the temperature by 0.3 to 0.5 degrees. And this happens 1 to 2 days after ovulation, but this is not so accurate. This is a typical biphasic graph, first part of the cycle and the second part of the cycle, but many women fail to record these biphasic graphs, even though they ovulate, and also basal body temperature may be influenced by many other irrelevant factors. So the most accurate method is to check the serum progesterone levels in the mid-luteal phase, and this is around 7 days before the expected period. And if we found that progesterone is above 3 nanograms, this can definitely document ovulation. We have also the urine nowadays very easily available in the market for the detection of LH surge, but this actually, the ovulation with these kids actually is assumed and happens the next 1 to 2 days. And also we have a bit of problems with the quality of the kits that are in the market, so it cannot be a definite documentation for ovulation. Also, we can document ovulation by ultrasound scan because we can see the follicle, irregular wall, and hypergenic areas inside the cavity. But this, of course, in order to do this, you have the lady must come to have serial ultrasound scans, and this is not always convenient, and also it's expensive. So in order to document the ovulation, the most accurate test is the progesterone measurement in the second part of the menstrual cycle. Endocrine evaluations, more specific endocrine evaluations, actually, according to the guidelines by ESE and ASRM, must be ordered on suspicion of some endocrine disorders like PCOS, polycystic ovarian syndrome, hyperandrogenism, or diabetes. And the endocrine evaluations include the FSH, LH, estradiol, prolactin, and androgens. Usually we get them on the cycle days 2 to 4. If there is amenorrhea or oligomenorrhea, then especially in late reproductive age, we have to check the FSH, because a high FSH and a low estradiol means ovarian failure. And the ovarian reserve. It is very essential for women of advanced age to be checked for their ovarian reserve. And fortunately, nowadays, we have the serum anti-Mullaria hormone, which is produced by the granulosa cells of the preantral and small antral follicles, and the number of the small antral follicles correlates with the size of the residual follicular pool. The serum level of the AMH do not show significant variation within the same and between consecutive cycles, so it is a quite useful and reliable measurement of the ovarian reserve. Low levels below 1 nanogram have been associated with reduced ovarian reserve. Be careful, low have proven neither sensitive nor specific for predicting pregnancy. Actually, they can predict the ovarian reserve. And here you can see the optimal range is according to age. Another way to evaluate the ovarian reserve is the enteral follicle count, the total number of follicles by ultrasound, 2 to 10 millimeters in both ovaries. It is a useful test, and along with the AMH, they can both evaluate the reserve. Previously common tests for this evaluation, like FSH and estradiol and site tests, are not nowadays with the AMH, they are not so popular. Also in the line investigation, all must be offered an ultrasound scan, either a 2D ultrasound scan or with a scan with the addition, the infusion of norsaline that helps some intracavitary lesions to be diagnosed, and of course with 3D high precision images, especially for the diagnosis of congenital abnormalities. And lastly, we have to check if the tubes are patent, if they are open. And the gold standard is an old test, the hysterosalpingogram, because it is non-invasive. We infuse a contrast agent through the cervix and we can have X-ray images. And apart from blocks of the tubes, we can check for other things, and especially for hydrosalpinx. That means that the tubes are not only closed blocked, but also they are damaged, including, and they have fluid inside. And this is very, very important to know, because it can affect the results of the IVF as well. And recently, we can do the same almost thing, the hysterosalpingogram, with a simple ultrasound through the infusion of a specific contrast foam through the cervix. And you can see here a perfect 3D image showing ultrasound image showing the tubes. Regarding the investigation of the male, apart from the medical history, which is almost the same, and the clinical examination, a first-line testing is the semen analysis. This has to be done 2 to 3 days after 2 to 3 days of abstinence, and we need 2 samples with an interval of 75 days between them. And here you can see, according to the latest update by the WHO, the normal thresholds, cutoff values for volume, concentration, and sperm count. Endocrine evaluation is indicated only in cases of suspected endocrine disease, or if we have significantly abnormal semen parameters. And finally, genetic evaluation is an evaluation that can be done as a first line in special cases before referring in order to earn time. And this actually is indicated in men with azoospermia or severe oligospermia, and includes a karyotype, because chromosomal abnormalities can be found in 10 to 15% of azoospermic men, with Klinefelter syndrome being the most frequent, and Y chromosome microdeletions, and these have a prognostic value, whether we're going to find sperm if we perform a testicular biopsy, and most importantly, mutations of the cystic fibrosis gene in cases of obstructive azoospermia.
Dr. Makrakis, please,
yes,
1 minute more.
yes, yes. From the urologic evaluation, we might ask for an ultrasound scan when EMAS is suspected, and a urine test after ejaculation in men with a very low semen volume. So, in conclusion, first of all, maternal age keeps at first childbirth, and for any other order keeps rising remarkably due to many changes in our lives. Fertility is defined as a failure to achieve a pregnancy after 12 months but of regular unprotected intercourse, but investigation should start earlier than the defined 12 months in cases of advanced reproductive age, because the advanced age is associated with a remarkable decline in fertility. For the investigation of the female, this includes history, examination, evaluation of ovarian reserve with AMH and AFC on ultrasound, documentation of ovulation, most reliably with PG levels, progesterone levels, endocrine evaluations on suspect of some endocrine disorder, ultrasonography, and hysterosalpingogram, classic or with ultrasound. And for the male, history, semen analysis, endocrine evaluation in severe cases of azoospermia or significant oligospermia, and genetic investigations in such cases. Thank you so much for attending.
Thank you for an excellent presentation and introduction to the field. Now Kristina will present the next speaker.
Thank you, Professor Makrakis, for the outstanding talk. And now it's my great pleasure and honor to announce our second speaker, Associate Professor Ljiljana Marina, one of the most distinguished experts in the field. Dr. Ljiljana Marina is an MD, PhD, and an associate professor at the Faculty of Medicine, University of Belgrade, and she works at the National Center for Infertility and Endocrinology of Gender in Belgrade, Serbia. Her focus areas are in the field of adrenal gland and reproductive endocrinology. Dr. Marina actively participated in the work of the ESE Young Endocrinologists and Scientists, and as a committee member and co-chair of EYES for the last 2 years, Dr. Marina founded the EYES newsletter and the EYES observership programs and was a member of the executive committee of the European Society of Endocrinology. She is a member of the expert panel of ESE Adrenal and Cardiovascular Endocrinology. She is also one of the co-authors of the latest ESE guidelines on adrenal incidentalomas. From 2021, she leads the Working Group 5 of the Cost Action Harmonization. In 2022, she was awarded the European Society of Endocrinology Special Recognition Award. Since February 2024, Dr. Marina has been elected as an European Journal of Endocrinology Rising Star. Dr. Marina is member of the clinical committee within the European Society of Endocrinology, and she is a member of the Serbian Medical Society, the Serbian Society for Menopause, and one of the founders of the Serbian Society for Adrenal Gland Diseases and Cardiometabolic Endocrinology. Professor Marina, many thanks for being here with us today, and I'm honored to say the stage is yours.
Thank you, Kristina, for this nice introduction. Dear Professor Hirschberg, dear EMAS representatives, Elena, Armeni, thank you for organizing this. This is truly an impressive start of your collaboration, and I'm thrilled to be a part of it and help get us to collaborate and learn more about female infertility and also raise awareness of the female health in general. Professor Makrakis, thank you for your nice lecture. And I have to say that just for the clarification, I'm the endocrinologist now talking after the gynecologist. And there will be a significant overlap between our slides. However, I will try to point some maybe different points than what Professor was talking about, and maybe give a little bit of the endocrinological point of view. So I will be talking about the female fertility facts and also infertility facts, defining the ovarian reserve, stratifying infertility, what is diminished ovarian reserve, what are the possible treatment strategies, and the take-home messages. When I was preparing this talk, what came to my attention that you can talk about fertility and infertility only by using three-letter abbreviations. And so this is how I designed this talk. And as we have heard, we are being born with up to 2 million eggs. However, until the age we are 40, we are left at 25,000. And also the birth rate declines sharply after the age of 35. So the infertility is the inability to achieve a successful pregnancy based on a patient's medical, sexual, and reproductive history, age, physical findings, diagnostic testing, or any combination of those factors. And as we have heard, we should be initiating the evaluation at 12 months after regular unprotected intercourse when the female partner is under 35, and at 6 months if the female partner is older than 35. So this is the 5th highest serious global disability. 1/3 of couples with infertility have a problem with the man, 1/3 with the woman, and 1/3 have a mix of both. Now, I want to show you this because this is very important in understanding the human fertility in total. So it's not only about advanced maternal age. Our fertility is not as promising when we are young as well. So you can see here when we are 25 years of age, odds of a natural pregnancy by age each month is 25%. This chance gets higher when looked through within the year to 86%, and then declines steadily to 78, 63%, and then 52% after the age of 35. There is not a lot of data about comprehensive causes of infertility, but as you can see here, this is interesting. It's a mix of endocrinology and gynecology factors, yet, as Professor said, you should test the endocrinology causes only if you have a suspicious of endocrinological cause. Now, I may discuss that and have a different opinion later through it when we'll have time for discussion. And this is very important because now we know that up to 30% of women will have infertility due to a diminished ovarian reserve. This is also very important, the spontaneous miscarriages as the cause of infertility, and it is rising in a different direction when taking into consideration the downsloping of fertility potential. So as we grow older, with age, the rate of spontaneous miscarriages gets higher, up to 51% in women over 40 years of age. And what about IVF? So we should not test the endocrinological causes, but we are now performing over 1.5 million IVFs, and the success rates, it's fantastic that we do have IVF, but it's not a magical thing. The IVF success is about 40%. So the number of oocytes needed to obtain at least one live birth increases exponentially with age. The increase in the number of oocytes necessary to obtain a live birth is associated with the biological aging of the ovaries, resulting in a progressive decrease in embryo euploidy rates with increasing age. Up to 24% of women will exhibit poor ovarian response to stimulation with exogenous gonadotropins, and consequently, low pregnancy and live birth rates are obtained, varying from 3 to 14%. I tried to look at the fertility rates prior to the 20th century. There is not a lot of data. Actually, I was looking for infertility rates. And what I came to the conclusion that we could only speculate based on total fertility rates back in the time. And this is one of the most comprehensive data set available online, which comes from the United States of America. And what you can see here, the total fertility rate in the US has changed drastically from the 1800 to 2020. So people have started planning their families accordingly with the change of lifestyle and the quality of life, and of course the freedom of women to choose what she wants. And now this is also important because this was not only the phenomenon within the United States, but also globally, worldwide. And the right for an abortion was a very important part of this process. And I have to say that we are very proud that even in 1974 in Serbia, the right for an abortion was a constitutional right of women to decide on family planning. And with the latest prediction coming from CDC, with the beginning of 2025, over 50% of women will plan first pregnancy after the age of 35. But not all of our patients are the infertility patients, and a lot of young women are coming to us to see us, and they are asking about their fertility potential. Now, I have designed here the fertility longevity term, as the patients are confusing the last stage, the age at menopause, as the last moment that they will be able to start planning their families. This is because they are not really aware that the fertility potential ends usually much before that time. And when it comes to infertility patients, they have only one question, and that is fertility success. So as you can see here, the three-letter abbreviation can be defined as diagnostic and predictor tools. They can be used to predict, to diagnose the conditions of premature ovarian insufficiency that we will be hearing about a little bit more later. Diminished ovarian reserve, and the possible outcomes are the poor ovarian response and live birth rate. So these are the 6 of these abbreviations that I and we use most frequently, most often in our everyday practice. And as we have heard already, the age has an important role, and it affects the probability of natural conception highly. And when it comes to FSH, unlike gynecologists, it seems, but not the gynecologists in Belgrade, we do measure it in patients with suspicion of diminished ovarian reserve, especially. We perform this measurement on the 2nd, on the 3rd menstrual cycle day. The reference values depend on the population and age. FSH can vary between the cycles. The high FSH levels are associated with decreased follicular development, oocyte yield, and embryo development in patients with a normal AMH and AFC. And it is very important in placing diagnosis of premature ovarian insufficiency as well. So for example, in between 7, 12, 25, and 40, there is a huge span on numbers where actually if you're waiting for 25 or waiting for your patients to get to the 40, you're already too late and you cannot really help with the fertility issue. The antral follicle count is very important. We do not perform it, as we have heard, Professor. This is something that is one of the most important tools in prediction, and also not only prediction, but diagnosis. I lean on this evaluation very much when I'm diagnosing, evaluating my patients, but also making decisions on how to proceed further. However, I'm not happy if I receive the report from a general gynecologist, and I am very happy if I see the AFC count coming in from the gynecologist who is an expert in the ovarian aging. Mother's age at menopause is very important, especially for the group of patients who is asking about their fertility potential and the possible age of their menopause. And this is where we are asking this question and paying attention to the history, as Professor said. Also, when evaluating our patients, we lean on the menstrual cycle length. The meta-analysis published in 2020 showed that even the short menstrual cycle, just short 1 day than the 28 menstrual cycle length, is significantly associated with lower ovarian reserve test values, reduced fecundability, and inferior IVF outcomes independent of age, and may be a sign of ovarian aging, which we know physiologically wise that it is later on in life in perimenopausal population, a definite sign of ovarian aging. Anti-Müllerian hormone in endocrinological world known as anxiety-making hormone. And yes, of course, it is very important. And thank you to Dr. Ben Moll from Monash University for explaining another phase of this hormone. It is very important to evaluate it, and it is also a very important part of prediction calculators. However, this is the only hormone that truly upsets our patients, and it is very important to keep this hormone within the measurement of this hormone within the indications. And ACOG just released a statement against the use of AMH in women without a diagnosis of infertility, as it is not supported by the evidence, and it has a huge place in PCOS, but we will not be talking about this today. ESE published a consensus in 2011, the so-called the Bologna criteria, primarily established to define the poor ovarian response. The idea would secure future prospective RCTs of a more homogeneous group when comparing new treatment modalities for poor ovarian response patients. However, the POR population, despite the 2 out of 3 criteria or collection of less than 3 oocytes in 2 prior ovarian stimulation cycles, independent of age or abnormal ovarian reserve test, showed to remain heterogeneous, primarily because the criteria did not adequately take the age-related impact on oocyte quality into consideration. And then further, it added to the confusion between POR as a response or an underlying diminished ovarian response as a cause, reserve as a cause of the POR. In 2016, we have seen the Poseidon classification being developed, and this is a very nice classification. We do perform it and lean on it quite often. Patients are subdivided into 4 subgroups based on quantitative and qualitative parameters: age, AFC, and/or AMH, and ovarian response if a previous stimulation was performed. And the expected poor responder patient, according to the age of the patient, is classified as either Poseidon group 3 or 4. And as you can see here, later on, the group has went further to publish the recommendation how to achieve or to try to achieve pregnancy in these patients. And what we see here is the measure of success, and this is very important, that on average, a total of 4 to 7 oocytes are needed to obtain 1 euploid blastocyst. That's for group 3, younger than the 35. And then here it says group 4, it says old. We never use old in our everyday work. I will say older than 35. The measure of success, this is also very important. On average, at least 12 oocytes are needed to obtain 1 euploid blastocyst. So the definition of diminished ovarian reserve is quite heterogeneous, and we still do not have a consensus on this. There is a big number of studies using different criteria. There is no clear age criteria. What is very dangerous, there is a significant overlap with POI. And ACOG is recognizing, for example, the diminished ovarian reserve as an AMH value less than 1, AFC less than 5 to 7, FSH greater than 10, so here is the FSH, or a history of poor response to IVF stimulation. These tests aim to stratify infertility patients and give answers to prediction. However, none of them on its own is helpful in identifying the infertility risk groups, and this is also very important. So coming back to this slide and the burning questions, all of these 3 letters abbreviations could be used in everyday practice, and as we see it, either for evaluating fertility or infertility, for evaluation or prediction. And if we are talking about fertility success, and as we have seen, yes, of course, we will use the AFC, AMH, age. There is a significant overlapping terms in using reserve and response. Some authors are even putting the sign equal in between the two. And of course, the statistically wise and the desired outcome is a live birth rate. But if my patient is asking me about her fertility potential, then I will also measure the FSH, look into her menstrual cycle length, try to find out everything I can about her history, find out everything I can about her mother's age at menopause, but I will not perform the AMH. And this is just a visual representation of something that we have put together with our gynecologist to, in short, show what we are doing simultaneously. So we are following the patient with DOR together, if needed, based on FSH and the look of the ovary. We add estradiol and progesterone. We perform the folliculometry each month. Then we add more estradiol and progesterone if needed. And then there is a decision that gynecologist makes based on the look of the ovaries, number of AFC, and the rise or the growth of the dominant follicle, whether they will simply perform the aspiration or go for a stimulation and then embryo transfer. So the multidisciplinarity is the key, and the process that I have just shown to you is dependent on age. Now, in our population, the 37, so it's on average 35 that we say that fertility declines, but the process that I have shown to you is we consider this process under the 37 years of age with respect to the oocyte donation, which means that we will talk to our patient immediately that after about 24 to 36 months of trying, we will consider the oocyte donation. And for the patients over 40 years of age, we will talk about this possibility sooner. So we talk to our patients about general fertility, age, and infertility facts, and all related contributing factors. We talk at the beginning of the possible outcomes and give time-oriented protocol. We evaluate mental health by using standardized depression and anxiety screening tests and involve psychologists and psychiatrists immediately if necessary and offer the talk to our specialized psychologist even though the tests are all normal. We embrace what she or they are going through and make sure that the entire process is organized and is going as smoothly as possible. We make sure that the patient is always given all information regarding all steps that she's going through. There is a lot of anticipation and hence a lot of disappointments along the way. First of all, we face the reality together. And then coming to folliculometry with or without stimulation. First, there is a hope for the follicles. Then the aspiration and retrieval, then hoping for the oocytes. Then we hope for the embryos, then the high quality embryos, then the implantation, then the positive beta HCG, then the doubling of the beta ECG, then the first ultrasound, then the heartbeat, then tackling with the high miscarriage risk. So now we are hoping to get to the week number 12, then 16, then 20. And at this point, we are not thinking about miscarriages as much anymore, and our chances are much better, but still we need to follow the cervix, metabolic parameters, if needed, hematological as well. And then after 9 months, we may be there for the delivery, which is on its own a high-risk event as well. So we have to be there for our patients. We have to embrace their feelings, understand them, and talk to them. Our patients appreciate the guided process based on facts and are more relaxed along the way than patients not knowing what is happening and what are the possible outcomes. In conclusion, diminished ovarian reserve now represents up to 30% of female infertility, some being very physiological because of the age. However, it seems that this number will go higher with chances of pregnancy most often less than 5%. Age does matter. Despite the prevalence and very low success rate, there is no definitive guideline nor consensus, as there are not enough of retrospective or randomized or prospective studies which would give us the answer which approach is the best. Individualized approach is of essence, and multidisciplinary approach is the best approach with gynecologists, endocrinologists, immunologists, hematologists, embryologists, urologists, psychologists, and psychiatrists all working together. And I thank you for your attention.
Thank you very much, Dr. Marina, for a very clear presentation. So Now we will move on to the last speaker, and I'm happy to introduce Dr. Sophia Kalantaridou, who is Professor of Obstetrics and Gynecology at University of Athens, Greece, and with special interest in premature ovarian insufficiency, POI. And she has received multiple honors and awards for her research. And the title of your presentation is How to Diagnose POI and What is the Indicated Management? Please.
Thank you, Angelica, and I would like to thank all the organizers. It has been a very nice webinar so far, although it's running a little bit late. I'll try to manage a little bit. So what is premature ovarian insufficiency, first of all, because we heard from the previous speakers that there is actually an overlap between a diminished ovarian reserve, advanced age. So when we are talking about premature ovarian insufficiency, we are talking about women who are less than 40 years of age. It is a heterogeneous condition. It may be a cause the initial follicle number, increased rate of apoptosis, or follicle dysfunction. So in most of the cases, we don't know what is the reason for premature ovarian insufficiency. Okay, so in order to make the diagnosis for premature ovarian insufficiency, as I mentioned before, we are talking about women who are less than 40 years of age. And first of all, we have to take a personal and family history, because very often there is a family history. We should check for secondary causes. And in order to make the diagnosis, we need 2 FSH levels, more than 25 units, at least 1 month apart. However, in some cases, antral follicle count and on ultrasound and AMH can provide supportive information. So if we have time, I would like to make a discussion with Marina, because I think that AMH has a value in cases with diminished ovarian reserve. So in terms of the testing, I think that we should have a karyotype in all the cases, because even in cases with secondary amenorrhea, we can find an abnormal karyotype, and definitely we should have the test for fragile X, because some women may have permutations, and if they have a pregnancy with a baby boy, maybe it will be with fragile X syndrome. So definitely because these women can have intermittent ovarian function, we need to check for fragile X permutations. Something else that I find it quite interesting in the recent years, as Evangelos showed before, there is a continuous decline in fertility worldwide. And I think one of the main reasons for that in young women is the environmental pollution and the climate change. So definitely one of the things that we should check in the history is occupational health and clinical history. So in the majority of the cases, we cannot find the etiology for premature ovarian insufficiency. However, now we identify more and more genes that are located in the long arm of the X chromosome. However, there are also autosomal genes that are related to ovarian function. And also we have to take a very careful history to see if there is any iatrogenic cause or infections or autoimmunity in these cases. And as I mentioned before, also we have to have a very careful history regarding endocrine disrupting chemicals, especially in the area that a woman lives. For example, I have seen some very interesting papers, for example, from certain areas in Sweden or in Italy, but women have a very decreased AMH levels irrespectively of age, and this have been related to the environmental pollution. So I would say that one of the main factors actually contributing to ovarian aging and premature ovarian insufficiency, apart from the known genetic causes, is the climate change, and this is something that we should have in mind. So if this is correct, and I think it is, I think that we should measure AMH, because in most of these cases, FSH levels are normal. But if we check AMH, we will find it very, very low. And there are several ways that environmental pollution may damage ovarian function. So we will take the basic history. We should check the basic genes, at least for Fragile X and a karyotype. And we should also have in mind environmental pollution, because actually we also know that environmental pollution is associated with an increased risk for infertility. This is just one of the interesting papers that I found, that if a woman lives like less than 50 meters then compared to a major roadway, it has a higher risk for infertility compared to a woman who lives greater than 400 meters from a major roadway. And for AMH, in order to discuss with Marina, if we have time, I think that it is a quite interesting assay to check for ovarian function, especially in order to make a diagnosis for a prodromal or occult ovarian insufficiency, even with normal FSH levels. And the reason is because actually AMH levels can decline at least 5 years earlier than the increase of FSH. And this is something that we see it actually quite often. Young women with normal FSH levels, but with extremely low AMH levels. And if we check the antral follicle count in these ovaries, we will also see that they have a very few antral follicles in both ovaries. Again, something that we should have very much in mind is the effect of chemotherapy in ovarian function, because also these days we have an increase in the diagnosis of cancer in young women, and we have very good treatments for cancer. So these women would like to have fertility potential after their treatment. And here you can see how AMH reacts during chemotherapy and after chemotherapy. Premature ovarian insufficiency is very important because it is associated with a decreased life expectancy. I don't have very much time to discuss that, but there are many papers showing that even in women with oophorectomy, they have decreased life expectancy if they don't receive hormone replacement therapy. Also, women with premature ovarian insufficiency have an increased risk for cardiovascular disease. Cardiovascular disease is the leading cause of death in women. And the first thing that these women have, women with premature ovarian insufficiency, they have impaired endothelial function, and hormone replacement therapy reverses this dysfunction. So definitely women with premature ovarian insufficiency should take hormone replacement therapy in order to protect their vessels, because actually estrogen are protective for cardiovascular health when there is a healthy vascular wall. And women with premature ovarian insufficiency have also an increased risk for osteoporosis compared to women with normal ovarian function. And this is actually true, and women with ovarian insufficiency should undergo bone density measurement as soon as the diagnosis is made, because they are at high risk for osteoporosis. Women with ovarian insufficiency also have sexual dysfunction compared to women with normal ovarian function. And actually this dysfunction is prominent even if they have partners or not. And those women who have the lower androgen levels are those with the lowest levels in their sexual function. And something that we found interesting in one of our studies is that actually 6% of women with premature ovarian insufficiency, they have no sexual intercourse, and they also have depression. Women with ovarian insufficiency do not have only estrogen deficiency, they have also androgen deficiency. We found that, and actually they have low serum free testosterone levels, and after hormone therapy, because of the decrease in LH levels, this deficiency becomes even more prominent because of the decreased LH levels following hormone replacement therapy. We try to give testosterone to these patients in order to substitute this testosterone deficiency. We achieved the good levels with a transdermal patch. So what is the appropriate management for these women? These women actually, as Marina mentioned, with women with diminished ovarian reserve, they need a multidisciplinary approach, from a pediatrician and a psychologist to a gynecologist and infertility specialist. They should have a very good initial workup and an annual workup continuously, because they have increased risks. We did a prospective randomized double-blind placebo-controlled study in order to see if we can give only estrogen plus progesterone, or we need to add the testosterone to the treatment. And we also used controls, women with normal ovarian function. We found that, but just giving estrogen and progesterone, progestogen is enough. And although we had some additive effect with testosterone, it's not recommended. We suggest to give it with a cyclical way, estrogen and progestin. First of all, because we would like to have them having periods every month. And also if a normal pregnancy occurs because they will have intermittent ovarian function, then they will have their endometrium prepared. So in conclusion, we know that women with ovarian insufficiency, some of them, they have genetic causes, and we know that quite often there is a family history. However, environmental pollution contributes a lot to ovarian aging and premature ovarian insufficiency, and I think is one of the leading causes that there is an increase in female infertility. And for that reason, actually, I like what President Obama said. We are the first generation to feel the effects of climate change, and the last generation who can do something about it. So in premature ovarian insufficiency, genes are involved, the environment is involved, some syndromes are involved, and also the treatment for cancer. And there is a multidisciplinary team approach needed for these women, at least until the age of natural menopause. And this is for how long they also need to take a hormone replacement therapy. And we had a review with Nick Panay, with Evangelos, with Lina Pascu 2 years ago regarding the management of premature ovarian insufficiency, which is free in PubMed, and you can have a look. Thank you for your attention.
Thank you so much, Dr. Kalantaridou. Now we have quite a lot of time for questions for all the speakers, and I think we could start from the top. And the first question is directed to Dr. Makrakis. And it's a question about males, the males that were studied in the paternal studies that showed decrease in number of Sertoli and Leydig cells. What age group were those males? Do you see the question? question?
It was, there are 2 or 3 studies. One of them actually included men, around 25 men between 25 years of age until 80 years of age, and they found a gradual decline, mainly in the Sertoli cells. And the other study actually mentioned a decline in Sertoli and Leydig cells in the age starting being remarkable after the age of 50 years.
Okay, thank you. Kristina, would you like to continue?
Thank you, Professor. Our next question is, repeated IVF could diminish ovarian reserve and accelerates menopause. So
Yes.
could repeated IVF, okay?
Yes, this is a very usual question.
Yes.
And the answer is that, as you all know, in every single menstrual cycle, actually from the luteal phase of the previous cycle, there are about 1,500 to 2,000 follicles recruited and start growing. From all these, only one, or in very rare cases two, actually will grow as mature follicles containing mature oocytes. So actually, by doing IVF, we actually go and take the what we can from this already recruited pool. So in any case, either you do IVF, either you take ovarian stimulation, these 2,000 follicles will be lost. So actually there is no decline in the reproductive years or an earlier menopause with IVF attempts.
Yeah, so the answer is no.
No, yes, the answer is no.
And you all agree?
Yes, actually, this is the case.
Very good. So we can continue with the next question. Let's see. At which level of the progesterone, luteal phase progesterone confirms ovulation? Who wants to?
Usually is the 3 nanograms. 3 nanograms.
Yeah, not all use nanograms. For instance, we use nanomole per liter.
Yes. The only another thing that I would like to mention here, it was in my slides, but I didn't have the time, is that some use the levels of the progesterone to let's say evaluate the function of the corpus luteum. And if you have high progesterone, then that means that the corpus is better functioning. And this is actually not true because, as you know, progesterone is secreted in pulses. So if you check the progesterone levels in the same lady in the morning and then in the afternoon and then in the evening, then you might find a variation which sometimes is remarkable. So there is a threshold for documentation of ovulation, but not a threshold for, let's say, the well-functioning or adequately functioning corpus luteum.
And I think it's also very important to collect the blood sample at the correct day.
Yes, of course. This is the approximately 7 days before the expected period.
Exactly.
Yeah.
Very good. Kristina, would you like to continue?
Certainly. So we have 3 questions from one participant. The first one is, how does a previous history of relative energy deficiency in sport affects future fertility?
So it talks about hypothalamic amenorrhea. Well, actually, in function, I don't know who wants to answer, but functional hypothalamic amenorrhea only affects the pulsatility of a gonadotropic releasing hormone. There is no effect in the ovarian reserve. So usually, actually, these women get pregnant quite easily, just either by normalizing their body weight or just by a very simple ovulation induction. So there is no effect in the ovarian reserve in these cases.
What we can add is that it's not unusual that they have quite low levels of AMH, and this could be misinterpreted as a low ovarian function. So because AMH is also related to testosterone levels, and usually they have low testosterone levels, but when they gain weight, testosterone will increase and AMH will also increase. But see, it's important to understand that the deficiency is not at the ovarian level. It's a central dysfunction. Okay, we can go on with the next question.
Okay, the following questions from the same participant is, how are egg reserves quality impacted? And the next one is menopause age delayed in patients with hypothalamic amenorrhea?
So I think that you have already answered that one with your previous.
Yeah, I think so too, actually.
Although I have to say that it cannot be excluded that there can be a POI in combination with the FHA. And I'm just having a patient like that right now. So it gets complicated. It can get complicated. We have to consider all the facts and simply have it in mind. This is a patient who has undergone a huge stress in her life. So we have had one baby successfully, and now we are trying for another one, but her response is simply not there. And she's fairly young still, 33 years of age. So it's probably that she has undergone the POI as well. However, this is challenging as it is impossible to test it in the setting of functional hypothalamic amenorrhea.
Yeah, and on the other hand, sometimes you can have functional hypothalamic amenorrhea, but with a polycystic morphology. So there is a lot of literature there.
Okay, we can continue because we have still time. And next question, I think it's about the relation with the mother's age at menarche and menopause with a patient's fertility.
So I think, so I did mention the mother's age at menopause a couple of times, and I think this one, the question was asked during my presentation. So first of all, I would like to stress how important these data are and how unreliable these data are. And this is something that even though we have to ask, we have to at the same time raise awareness about the menstrual cycle diaries and about the menstrual cycle family history, which should be documented and not as in a paper, but to ask your mother as soon as possible, or for a mother to tell the child as soon as possible. And I remember how difficult it was for us, for example, to publish the paper on the mother's age at menopause in POI patients, because, when you detect POI, on average, they are already in POI somewhere in between 3 to 5 years, and not all of them have the menstrual cycle calendars in their cell phones or the papers, or they have lost it. So you have to rely on retrospective data, and you cannot predict the patients with POI as yet that easily, so there is no prospective data. So the menstrual cycle health and the information regarding the menstrual cycle is crucial, and this is something that we need to all work together, how important it is, and to insist on asking these questions to our patients and their families, because These processes are highly genetically determined, and yet the Mother Nature has made it sure that we do not get the genes that easily, or to realize which genes are working together, because it's obvious after all these studies that we have had that it's not only one gene, not the cluster of genes, but this is genetically multiple directed process, and the most importance for humankind. So yes, we do ask, yes, it is important, yes, it is genetically determined, yet I cannot tell you at this moment if the mother's menarche may be a predictor of infertility later in life. Maybe the professors would have something to add, but to my knowledge, what we know is the mother's age at menopause does matter, and it's been proven, but the menarche are not so sure, but maybe I did read about it or forget, maybe somebody can help.
No, actually, for menarche, no, we do not get a lot of information from the age of menarche regarding the risk of infertility or the age of ovarian failure or menopause. Definitely, the age of menopause, it is a crucial, as Marina also mentioned, and I mentioned. So, not only from the mother, but the relatives also. So, a very good family history. It is mandatory, at least to prevent infertility in some girls. For example, if there is a family with 2 or 3 or 4 relatives with premature ovarian insufficiency, at least the girls in the family should be informed that there is a risk for ovarian failure, and they should test their ovarian reserve in order to make their plans for fertility.
Thank you. We can continue. Would you like to continue, Kristina?
Certainly. So our next question is for Professor Kalantaridou. Could you please elaborate how climate changes are related to infertility?
There are several mechanisms for that. And actually, we summarized this mechanism in a review article that it was just published in Maturitas. So there are definitely several ways and affecting both the oocyte and the granulosa cells and the axis. So it can affect environmental pollution and endocrine disrupting chemicals in various ways ovarian function, not only by accelerating ovarian failure, but also some chemicals, especially those for makeup, and the plastics can also affect ovarian function for like polycystic ovary syndrome and obesity. So climate change makes a lot of disorders in ovarian function.
Thank you. Then there's another question, not related to fertility, but to HRT. When is it not too late to initiate HRT in women with POI? Who wants to answer that question?
Well, women with POI, actually, they have, as you mentioned earlier, they get a delay in the diagnosis, at least 2 to 3 years, but they should start having HRT as soon as possible. According to our recommendations, I'm talking about the ESE recommendations that actually we are currently updating. We recommend cyclic hormone replacement therapy until at least the age of natural menopause. And after the age of natural menopause, then they will have a discussion and a choice based on what are the data for women with normal menopause. But at least until the age of 50, they should take hormone replacement therapy because it is a true replacement therapy.
Good.
Thank you. So our next question is from women with POI. Is better to use patch or gel of testosterone?
We do not recommend either thing for testosterone. because so far we did not find a clinical effect in bone density or in other parameters. The only finding that we find by giving testosterone to these women, it was a decrease in fat mass. It was the only one that it was significant. We had a small increase in bone density, but it was not significant compared to women taking only estrogen. So for now, the recommendation is to take estrogen throughout the cycle, either transdermal or in a cream in a parenteral way. So we avoid the first pass effect, but there are no recommendations so far for testosterone, although there are some studies in the field, especially for the management of low libido. But I have to tell you that in our 3-year study, we found actually absolutely no effect after the 3-year testosterone treatment in women with ovarian failure, despite that at baseline they had severe sexual dysfunction.
Okay. What about general life quality?
Even in quality of life, we did not find actually the change was exactly the same between women taking estrogen only and the women taking estrogen and testosterone. That was a big disappointment because I was the primary investigator and I was hoping to give a new treatment by adding physiological testosterone replacement, but we have to respect what the data show.
Yeah, I have to add that I agree, and this is one of those moments which shows that POI is not the menopause; it's different, and where the women are reading obviously and getting informed, and then they want testosterone, they ask for it immediately because they want their strength back and they want their libido back. But as you have said, Sophia, what we usually do, we have this long conversation and we say, could we wait just for a little while and give some space to estradiol and progesterone to do their own thing? And then the brain, once it's estrogenized again, does its own thing. And then after a couple of months at the reevaluation, while talking to the patient, she, of course, it's individual response to the treatment as well. And I think that pharmacogenomics will help us here, whether we start with oral or go straight to transdermal. This will be a tailored approach quite soon in the future as well when it comes to steroid treatments. And so then we talk to them and we see that there are no more complaints regarding this.
And the other thing is that in women with normal menopause, we have decreased adrenal androgen production too. In ovarian failure, it's only androgen from the ovaries.
I think we have time for a last question, and maybe we can pick this one because we have not talked so much about egg donation. In which cases is IVF with donated oocytes recommended? Maybe
I don't know if Evangelos wants to answer.
You can comment. Who wants to start?
You see, it's always a difficult answer to this, and I would, of course, if you have an amenorrheic woman with undetectable AMH levels, and she wants desperately to get pregnant, you cannot stimulate these ovaries. And we can see that you cannot stimulate them. What I usually advise them is to wait for a period of 1 or 2 years because spontaneous ovulation and spontaneous pregnancy actually in young ages is much more probable and frequent than IVF pregnancy with her own oocytes. Of course, there are other things as well. There are social factors, relationship factors, and so there is no specific answer about the premature ovarian failure and when to start having donated cycles. If you ask me about the late reproductive age, which was a topic of my lecture, I would mention that the oldest accepted age that has been reported as a case report is the age of 46 years old with a pregnancy with autologous oocytes, and this is the oldest. So if you ask me for the late reproductive age, I would say that the advice is that above 46 there is no reported case apart from one from India. But for the younger ages, I have seen many, at least 5 to 6 spontaneous pregnancies in women taking HRT.
Yeah, and actually I see it every year. We have to wait. In women with ovarian failure, we have to wait. There's no reason to rush, oocyte donation, because perhaps they may have a spontaneous ovulation and pregnancy.
I don't know if I am right, but because if as younger is a lady, then perhaps you might prefer to give a contraceptive instead of the classical HRT. And this is something that has been proposed, because actually they need more estrogens than what the traditional HRT can provide. So what I would recommend is for young women that want to get pregnant, just give them the low-dose HRT regimen and no higher doses, because a low-dose HRT regimen does not block an ovulation if this happens.
Well, I can tell you that even by taking contraceptives, a woman with POI can get pregnant. And there are several case reports, and I have seen it also in my practice. And actually, we have to inform these women that if they decide to take contraceptives just as a hormone replacement therapy, and they want to avoid pregnancy, they should use barrier contraception. There is a chance of getting pregnant. And the other thing is that I usually do not recommend oral treatment, because you have the first pass effect and you increase the risk for thrombosis. And because the mean age of ovarian insufficiency is 32 years of age, so these women will take hormone replacement therapy for 20 years. And I don't agree about the dose of estrogen, because actually that will increase the risk for osteoporosis and bone loss. Actually, hormone replacement therapy, especially in a transdermal way, does not prevent spontaneous ovulation. And this is something that we should tell these women, that by taking hormone replacement therapy, this will not avoid a spontaneous ovulation if that will occur. So by giving a low dose, it will increase the risk for having osteoporosis later on. And this is actually very important information for them, that therapy doesn't.
I think this must be the last concluding remark, which is very important. And because time is out, but I would like to thank all the speakers for excellent presentations. I think it was a very nice overview of this field. And I would also like to thank you to my co-chair. And I really hope that all of you, the audience, that you will come back tomorrow for the next part of this session. Kristina, would you like to add something?
Thank you, Professor. First of all, I would like to thank all the speakers for the eye-opening lectures and enriching this webinar. And also, I would like to extend the invitation for tomorrow's webinar, which will be on menopause. We will have distinguished experts, fantastic chairs, and we'll be opening quite dynamic discussion.
Thank you so much, and goodbye.
Thank you.
Thank you. Goodbye.
Thank you. Bye.
Bye.